Hello, and I'd like to thank the organisers for asking me to talk at the Paul Strickland Scanner Oncological Imaging course. Today I'm going to talk about imaging in lung cancer, disease response and toxicity. Unfortunately, due to slight technical difficulties, I don't have a radiologist to hold my hand, so I'm kind of going solo, but I'm sure you'll bear with me on that. So, what learning objectives do we have for this lecture? I'd like to talk a bit about the imaging findings in thoracic malignancy, a bit about radiotherapy changes, and a bit about the assessing the response to systemic anti-cancer therapies, including the newer agents and the potential pitfalls that can arise with these newer agents. So, case one, she was a 72-year-old lady who presented with a persistent cough. No other symptoms, constitutionally well, performance status 1 despite her age, out and about, doing everything that she wanted to do. She was diagnosed with a T4N2 M0 squamous cell carcinoma of the left upper lobe, which I can show you here. You can see the obstruction of the left upper lobe orifice and the collapse of the left upper lobe in the upper picture, and in the lower picture you can see the narrowing of the left lower lobe bronchus as well. PET scan shows activity centred around the bronchus. It's a squame, so it's central disease only. The collapse is not lighting up in PET, so we can be pretty confident it's just simple collapse due to a central tumour. It was felt that because her collapse was obviously probably reasonably long-standing, she'd had a cough at that point for a few months, that initial endobronchial treatment would not open up her airways. So she was referred to me for radical treatment, which was given as concurrent chemoradiotherapy, cisplatin and etoposide together plus 66 gray and 33 fractions over 6.5 weeks. And despite her age and despite the fact that she had a non-functioning left upper lobe, she coped extremely well with treatment and she had a good response to treatment. During treatment, interestingly, her left upper lobe did inflate a bit, and therefore the whole of her lung reinflated, so we were very concerned that we were actually going to be missing the cancer because the cancer moves. However, we did a repeat scan during treatment and matched where her cancer was and where we were treating to the area where it had been prior to the reinflation. And in fact, although her lung had reinflated and you could see quite a change inside her chest, her cancer, because it was so attached to the mediastinum, actually hadn't moved, so we didn't need to replan this lady. We scanned her at 4 weeks following treatment. The top two panes are the pre-treatment CT scan and the post-treatment CT scan. You can see a considerable reinflation of her left lung there, and you can see the left upper lobe now open and a bit of scarring in that left lung. The bottom is the bottom pane is the slightly lower view post-treatment with, again, continued reinflation of that left upper lobe, but some persistent scarring in the lung. And she's quite interesting because she was scanned at 4 weeks after radiotherapy, which is quite early, but for now we have access to adjuvant immunotherapy for certain people. So as part of the Pacific trial, durvalumab adjuvantly or placebo was given following concurrent chemoradiotherapy to those who had PD-L1, which is the measure we use for likelihood of response to immunotherapy, of all status, so from 0 to 100%. This was shown to improve progression-free survival and overall survival, which is a significant improvement for lung cancer. And there were a number of grade 3 or 4 side effects, approximately 30% in the treated group versus 26% in the placebo group. So actually still quite a large amount of grade 3 and 4 events in a group who were not receiving active medication. And in the treatment group, 15% of patients discontinued treatment due to toxicities versus 10% in the treatment group. In the UK, because of the way the data was presented, we do not offer adjuvant durvalumab to those who have 0 PD-L1. Durvalumab is an immunotherapy agent. It's given intravenously every 4 weeks. Initially it was every 2 weeks, which was a huge burden as it's given for a year, but we've now managed to move it to every 4 weeks with supporting pharmacokinetic data. This patient remains well. She has no side effects related to her immunotherapy, which is good. And we have scanned her as we would routinely do at 6 months post chemoradiotherapy, so that's halfway through her adjuvant durvalumab. And the top pane shows that indeed her left upper lobe collapse is slightly increased, but you can see the emerging radiation changes in that left lower lobe there. And on the bottom pane, you can see her 4-week post scan compared with her 6-month post scan, and there is a degree of increased left upper lobe collapse, and there is a suggestion that the soft tissue around her left upper lobe orifice is slightly increased. So I think we have essentially accepted that things are slightly different, but one of the things we're finding with durvalumab and the immunotherapy agents is that while with standard chemotherapy things either stay the same, shrink or grow quite regular with quite predictability, with the adjuvant immunotherapy treatments often you're finding a bit of variability as you scan people. The response waxes and wanes. So what you can see in this scan is the emerging radiotherapy change, as I said, but I think the slightly increased volume of disease around the left upper lobe orifice and the slight increase in collapse, at the moment I am not significantly concerned by. So we're doing a watching brief at the present, especially as the lady has no cough and no other respiratory symptoms of note. So if we move on to case 2, he's a 66-year-old gentleman who presented at the start of the pandemic. He presented bang in March 2020. Which was a very tricky time for us all. We didn't know what the impact of the pandemic was going to be on our patients with cancer. We didn't know about the interaction of the pandemic, of the virus, with either radiotherapy, especially in the lungs, or with chemotherapy. And we actually didn't know if we were ever going to be able to treat people, get them through a course of treatment because of staff sickness. He had hepatitis C in the past, although it was no viral load at the present time, and he had a cardiomyopathy, and indeed it was during investigations for his cardiomyopathy that the tumour was found. And here you can see the cancer in his right lower lobe. If you look at the third picture, there's a significant ingrowth of the cancer into the right lower lobe bronchus. And also in the bottom picture there's a small nodule in the right lower lobe which was not PET positive but was of slight concern. Because of the position and that invasion into the lower lobe bronchus and the proximity to the vascular tree, it was decided that he was not an operative candidate. Also at that time, the surgeons were beginning to struggle to be able to operate, partly because of the staff-related issues in the pandemic, but also because there was an indication that anybody catching COVID immediately after surgery on the thorax had an exceptionally poor outcome. So there was a significant reluctance on the part of the surgeon to operate on him. Here you can see his PET pictures. The bottom one is where the nodule would be, so there was no PET positivity. So I decided to treat him as a potentially curable patient. We talked about concurrent chemoradiotherapy, we talked about sequential chemotherapy followed by radical radiotherapy, or we talked about radical radiotherapy alone. At that time we were operating the 6-week concurrent chemotherapy schedule, and I did say to him that I felt, given the fact we had 20% staff sickness amongst our radiographer colleagues at that point, I could not guarantee that we would finish the treatment. And with radiation, if you start, you really need to finish. With sequential chemotherapy, we would have 12 weeks of chemotherapy where we didn't know what the impact of the virus would be on an immunocompromised patient were he to catch it, but we suspected the outcomes would be very poor. Actually, what we found with coronavirus is that it is the having an active cancer that is a much, much bigger prognostic factor for solid tumours than actually having chemotherapy and being immunocompromised. And we talked about radical radiotherapy, which I explained to him was less chance of a cure, but given the fact we could treat him with chart, which would be over within 12 days, I was pretty sure we could get him finished and treated before the massive wave of the pandemic hit and before we had significant staff shortages. I also felt, given his cardiomyopathy and his hepatitis C, that chemotherapy was also quite a tricky option. After a long discussion, we opted to proceed with chemotherapy alone. He finished his radiotherapy in March 2020 before the full blast of the first wave hit. And his initial CT scan showing response in May 2020 showed a good response. This continued in November, but unfortunately in February of this year, he had significant progressive disease with a collapsed right lower lobe. I petted him and there was a pleural nodule as part of the general collapse. So it wasn't just a local regional collapse, so there was a pleural disease collapse. And it was felt, given the nature of that pleural nodule, that he was not suitable for surgery at this point. He had a PD-L1 of 80%, and therefore I commenced him on single agent pembrolizumab in April 2021. Following his first cycle, he was admitted within 3 weeks with significant hemoptysis, and here's the scan at that point. So you can see in the top that there's significant cavitation in the right lower lobe. This, at his initial relapse, that had been completely consolidated. You can slightly see the contrast in the vascular tree very close to that cavity, and the disease pushing into the back of the left atrium. In the middle panel, you can see again cavitation, and you can see another blood vessel running in the wall of that cavity. And in the lower panel, what you can see there is something we weren't entirely sure of. Was that blood in the alveoli? Was it radiation change? Was it part of the consolidation because his consolidation had cleared slightly lower down? Was it just still detritus from that consolidation, or was it disease? But certainly the upper two pictures were a slightly concerning thing, and we had a further discussion at the MDT. The cavity was felt to pose a large infection risk. He also had the potential for further catastrophic hemoptysis, especially if there was further necrosis of the tumour, both locally with the pulmonary vasculature, but also that left atrial invasion was quite worrying. There was a concept of fistula formation, either bronchopleural fistula or into the blood vessels again. So we sat down with the gentleman and we had a chat with him, and he actually had, despite the hemoptysis, which had obviously worried him, he'd actually felt better with the immunotherapy. He felt less breathless, he felt his appetite had improved, his energy levels has improved, so he felt he was benefiting from the treatment, and he was willing to take the risk. He knew he was incurable, so he felt that it was better to proceed with treatment than not. Here you have the picture 2 months later, after 2 cycles of treatment, showing that the cavity has begun to resolve, and there is aeration in that right lower lobe, and also the disease pushing into the left atria has receded. Again, here we have a resolution of the cavity and no obvious blood vessels quite so close as before, and a resolution of what I thought was perhaps radiation change or perhaps bleeding in that right lower lobe. We'll never know, but anecdotally, some of the radiation change, which is scarring, which is often being reduced in immunotherapy patients. So it's a very different discussion that I have with my radiology colleagues when we are looking at people who are having immunotherapy, especially after radiation. It's a very tricky discussion. It's very tricky on a single CT scan to make a decision on whether we should proceed or not proceed. So case 3, a 51-year-old lady, when she presented in April 2015, with a right lower lobe tumour, and she had a lobectomy at that point for an adenocarcinoma. She was offered adjuvant chemotherapy as she had nodal involvement, but this was discontinued after one cycle due to an episode of significant neutropenic sepsis. She relapsed in May 2018 with pleural disease, a pleural effusion, and multiple lung nodules. Rebiopsy showed that she was ALK positive, and she was started on what was the optimal first-line treatment at that point, a drug called crizotinib, an oral TKI inhibitor for ALK-positive disease. She was treated from June until January 2021, showing significant resolution of her disease, which then progressed in January 2020. And here is the CT scan in January 2020. You have she presented with dizziness and headaches, and you can see that she has a significant lesion inside her posterior fossa. She had multiple supratentorial lesions as well. ALK positive disease actually predisposes to intracerebral metastasis, but often they do not have a significant edematous reaction for some reason, and they often can be stable for quite prolonged periods of time. ALK, central nervous system disease in ALK positive patients, is an odd thing. You can see she had some significant pleural thickening at all levels in her chest. She was commenced on brigatinib, which was not available when she had initially presented in 2018, in February 2020. So this was a drug that was now available, and I would now normally use first line for patients. But again, because she had been started on crizotinib, there was the option to switch her to brigatinib. This is one of the second line drugs for ALK positive patients. It has significant progression-free survival over crizotinib. It probably has an overall survival benefit, but it's very difficult to see that in terms of often the trials have crossover. But what it does have is significant CNS penetration and much less incidence of brain metastasis. The side effects are quite interesting. Patients can get diabetes, they can get significant hypertension, and when I say hypertension, I mean severe hypertension. One of my patients ended up with a blood pressure of 240 over 180. They can get swollen ankles, and they can get visual disturbances, which are described as auras around objects, colourful auras around objects, or sparkles. It sounds quite pretty, actually, obviously not to the patients, but none of my patients have ever had them, so I don't, all I have is what the literature says. So we started on this, and we rescanned her after 3 months, and here there is the second CT head hasn't got the same quality because there was a bit of mobility. She moved a bit during the scan, but you can see there is actually a complete resolution of that posterior fossa lesion. The mediastinal pleural thickening anteriorly is almost completely resolved, as is the nodal disease at the left hilum. She has significant reduction in the pleural disease lower down as well. So she has continued on brigatinib actually until August of this year, when she relapsed again, and we now have a third agent we can treat her with, so she has moved on to lorlatinib at the present time. And she seems to have had a symptomatic response as well, although it's not within the time frame that I would scan her. So it's not the best news, but she has survived 4 years with significant metastatic disease, which I think shows that we have in many ways impacted massively on the paradigm of lung cancer survival, changing it from an immediate death sentence to a much more chronic disease, and that also changes how we need to look at patients and how we need to support them through that illness. Case 4 is a lady who presented in December 2018 with multiple intrapulmonary nodules, N2 disease, and multiple bony lesions. She also had lymph nodes in her left axilla and her celiac axis. She had a biopsy of the axillary lymph node, admittedly only a core biopsy, not an excision biopsy, but only lymphoid tissue was found. And therefore, there was a tentative diagnosis made that she had a low-grade NHL in addition to her adenocarcinoma of the lung, given her significant metastatic disease burden. It was felt that the low-grade NHL could be ignored safely, and the haematology MDT fortunately agreed with us. She had a PD-L1 of 70%, which is again high PD-L1, which allowed us to treat her with single-agent pembrolizumab. She commenced that at diagnosis and was treated for about 7 to 8 months with this, when she developed significant fevers, a skin rash, and a significant transaminitis. When we reassessed her disease response at this point, her lung disease had shrunk away, her bony disease was much more sclerotic, but the lymph nodes were unchanged, and we thought slightly unusual. We would expect low-grade NHL to recede with immunotherapy, but she had overall not progressed in any area, and therefore we felt that she, given her the toxicity, she would stop her disease and there was no need to switch her onto a new disease. She was quite keen to have a bit of a treatment break, so we commenced active monitoring from June 2019. This was the scans at that point. The nodule in the upper panel was all that remained of our multiple intrapulmonary nodules. It was the sole standing one. In the middle panel, you can see the lymph nodes, and in the lower panel, you can see a focus of scarring and disease at the right pleural nodule. In March 2020, she had multiple episodes of biliary sepsis, some of which had required admission into the hospital for intravenous antibiotics, some of which had made her jaundiced, and she felt the lymph nodes in her axilla were enlarging. And so we decided to take the bull by the horns and biopsy her axillary lymph nodes again. Her celiac axis lymph nodes were slightly enlarged as well, but given the fact that the lymph nodes were enlarging but her other disease was not, I was willing to believe that she did indeed have the low-grade NHL, but I wanted to be sure of that before making a treatment decision. And we did a core biopsy again, and this time her disease came back as adenocarcinoma of the lung. So it seems that we had made not necessarily a wrong decision all that time before at diagnosis, but we had assigned her to having a possible low-grade NHL when indeed she had always had adenocarcinoma. Lymph nodes, adenocarcinoma in a contralateral axillary lymph node, rare, but I have seen it. Celiac axis lymph node, less rare, but not common by any manner of means, especially when the disease is not a significant lower lobe tumour, which she did not have. She just had disseminated multiple nodules. So in many ways what she had was progressive disease and it was lung cancer, so we ordered a restaging CT. And here you can see the top panel was her scan from July 19 and the bottom panel is the scan in March 2020. So her lung lesion was the same. It was unchanged. That pleural nodule, top panel, is June 2019, or July 2019. Or July 2018 actually. The bottom panel is 2020, March 2020, and you can see it's unchanged. What you can see, however, is that her lymph nodes have continued to increase, and there is also a suggestion that her breast is enlarging. When we showed her the scans, she was very keen not to proceed with any treatment. She felt that although she was aware that the lymph nodes were enlarging and she could feel them, they were not painful, they were not causing problems. And she was comfortable, given that every other part of her disease was well under control, just to continue with an active monitoring. And she also was worried about the next option for her was systemic anti-cancer therapy, and she was slightly worried about her biliary sepsis, and I too was very worried about her biliary sepsis. So actually what we did was we pushed the surgical team to say that she had multiple episodes of biliary sepsis, which would prevent her having chemotherapy. Her survival was good, her disease hadn't progressed, and could they accelerate her cholecystectomy, which they did. She took some time to recover from that and was still keen not to pursue treatment. However, by December 2020, her left axillary mass had enlarged and she had significant lymphedema of the breast, and I gave her radiotherapy to that area. She was very keen still to avoid systemic anti-cancer therapy at that point, although she was showing further progression in her celiac axis lymph nodes at that time. She had a very good response to radiotherapy. However, shortly after that, she had further enlargement of her celiac axis lymph nodes, which caused biliary obstruction, and she had an ERCP and a stent placed, and at that point she decided that her disease had progressed far enough that she wished to have chemotherapy, and she has had 4 cycles of chemotherapy thus far, and has had some problems with the stent, but has had stable disease.